It's time for another warm-up. Let's get going. First question here. A 15-year-old girl of normal height and weight for her age has enlarged parotid glands but no other complaints. Her mother confides that she found laxatives in her daughter's closet. What is the most likely diagnosis? So this is probably an abuse of laxatives, and the enlarged parotid glands are a clue that she has been vomiting a lot. So she is purging, but she is maintaining a normal weight. So this is bulimia nervosa more likely. If she was underweight, this could be more likely anorexia, but because she is of normal weight, we think more bulimia. Next, which defense mechanism best fits each of the following descriptions? So we have involuntary withholding of a feeling from conscious awareness, so this is going to be repression. A veteran can describe horrific war details without any emotion, this is going to be isolation. A child abuser was himself abused as a child, that's going to be identification. Underlies all other defense mechanisms, that's going to be repression. May lead to multiple personalities, this is going to be disassociation. Adult whining, bedwetting, and crying, that's going to be regression. All right, that's it for the warm-up. Let's get to that lecture now.
Previously on Doctors in Training.
Now, this is a story about how my life got flipped, turned upside down, and I'd like to take a minute, just sit right there. I'll tell you how I became the prince of a town called Bel Air in West Philadelphia. Born and raised on the playground is where I spent most of my days chilling out, maxing, relaxing, all cool, and all shooting some b-ball outside of the school. When a couple of guys who were up to no good started making trouble in my neighborhood, I got into one little fight, and my mom got scared and said, "You're moving with your auntie and uncle in Bel Air." In this video, we're going to talk about leukemias, and all of this will make sense later, but not yet. The first thing you have to understand about leukemia is how we classify it. We classify leukemia based on whether it's acute versus chronic, and then also based on whether the malignant cells are lymphoid cells or myeloid cells. So lymphoid cells are lymphocytes, and the myeloid cells are the granulocytes, like neutrophils and basophils and eosinophils. Now, I'm going to focus on the notes in your study guide as we go through the different types of leukemia. Let's start with acute leukemias. So first of all, what's the difference between acute leukemia and chronic leukemia? Acute leukemia has a rapid onset and is rapidly progressive. In acute leukemia, over 20% of the cells in the bone marrow are blasts, either myeloblasts or lymphoblasts. So if you see a lot of blasts, you know this is an acute leukemia. If they're myeloblasts, that's AML, acute myelogenous leukemia. If they're lymphoblasts, that's ALL, acute lymphoblastic leukemia. But the hallmark is numerous blast cells. And these blasts in the bone marrow eventually spill out into the peripheral blood. So if more than 20% of the leukocytes in the peripheral blood are blast cells, that's an acute leukemia. And acute leukemia is so disruptive to the marrow that it's often associated with pancytopenia as well. So now look at the table. Let's talk about ALL first. The Philadelphia chromosome may be seen with ALL, but typically when we say Philadelphia chromosome, we're talking about CML. Now, we'll talk more about what Philadelphia chromosome is when we get to CML. For right now, just remember that Philadelphia chromosome is CML, but it may be associated with ALL and very rarely with AML. Now, ALL is most common in children and young adults. There are a bunch of morphologic and phenotypic variants of ALL, which thankfully you don't really need to know. Bone pain is common with ALL. There's a good prognosis in children. Up to 90% of children with ALL will have remission. Most malignant cells in ALL are positive for an enzyme called TDT, or terminal deoxynucleotide transferase. That's worth knowing, positive TDT with ALL. And ALL is relatively difficult to diagnose on the peripheral blood smear alone. The other thing I want you to make note of is that Down syndrome is associated with ALL. So you need to remember that. There's a mnemonic, we all fall down, like Ring Around the Roses. We all fall down, and the all is ALL. So ALL is associated with Down syndrome. And we're going to see in just a second that Down syndrome is also associated with an increased risk of AML. Then over on the AML side of this table, very, very rarely you might see the Philadelphia chromosome. You might see hour rods with AML. That's definitely a high yield point. So hour rods are thin, reddish-pink rods that you see in the cytoplasm of the myeloblasts in AML. So when you see them, think AML. When you see hour rods, think AML. Now these can be seen in any type of AML, but they're especially common in the M3 variety of AML, which is also called acute promyelocytic AML. Again, there are a bunch of different subtypes of AML, which are called M0 through M7, and you don't really need to bother with them. But think about it. Myeloid precursor cells give rise to a bunch of different cell types, like granulocytes and monocytes and red cells, and even megakaryocytes and platelets. So depending on what stage of the myeloid precursor underwent malignant transformation, you might have an AML that makes myelocyte precursors, or AML that makes monocyte precursors, or red cell precursors, or even megakaryocyte precursors. And again, that M3 subtype with our rods is called acute promyelocytic leukemia. That's a subtype of AML. Now, the next bullet in the table says most types of AML are CD13 and CD33 positive. The age of onset is typically around 60 to 65. The median age is actually 65. So ALL is mainly a disease of children, but AML is seen in middle-aged adults or slightly older adults. I like to remember that the myeloid leukemias, AML and CML, occur in midlife. So remember ML for midlife. And then the lymphoid leukemias occur on the extremes of age. ALL is seen in kids, and CLL is seen in the very old. And then AML is associated with numerous risk factors, which are listed in the next question. These are a lot of the same risk factors that we saw with aplastic anemia. Radiation is a big one, benzene, alkylating agents, and myelodysplastic syndromes. I'm not going to read all these to you, be aware of them. And also, you'll notice that Down syndrome is there again. Let's move on to the chronic leukemias. So again, what are the defining features of chronic leukemia? Well, you have insidious onset and gradual progression instead of the rapid onset we saw with acute leukemias. Acute things move very quickly, chronic things take more time. It's pretty easy. With chronic leukemia, there are mature cells rather than all those blasts. So if you see less than 5% blasts, that's chronic leukemia. The way I think about it is this is a chronic process. It takes a long time to develop, so there's a lot of time for these cells to mature. It's not perfectly accurate pathophysiologically, but it's conceptually pretty easy to grasp. And again, if you see mature myelocytes, that's chronic myelogenous leukemia, or CML. If you see mature lymphocytes, that's chronic lymphocytic leukemia, or CLL. So chronic leukemias can be associated with hepatosplenomegaly and lymphadenopathy. Then the bone marrow is going to be infiltrated with leukemic cells, and the peripheral white cell counts may be high. So if you see an older individual with elevated white count, you don't know why it's elevated, think about chronic leukemia as a possible cause of that. Then look at the table. CLL is seen in elderly adults. The median age of diagnosis is 70, and the incidence is higher the older you get. Remember, we said that myeloid leukemias, AML and CML, tend to occur in midlife, but the lymphoid leukemias occur at the extremes of age. So think about CLL in the very elderly. It's certainly not unheard of, though, in the 50s or 60s. Most types of CLL have B-cell markers, so these are going to be B-cell leukemias. And then the characteristic cell in CLL is called a smudge cell. Smudge cells are lymphocytes that instead of having a nice round nucleus, the nucleus is larger and irregular, and the cytoplasm is sort of smeared. It sort of looks like somebody took their thumb and smudged it. So you can also see autoimmune hemolytic anemia with CLL. We talked about that earlier. Now, do you remember which type of autoimmune hemolytic anemia? Does CLL cause warm agglutinins or cold agglutinins? It's both, actually. CLL can cause either one. And CLL tends to be indolent. It means it can last for years and years and years without any real significance. So often we just monitor these CLL patients for progression, especially if they're really old. You know, you got a patient in their 80s, you just monitor the CLL and see if it's going to progress. There's a good chance that they're going to die of some other chronic disease before the CLL actually causes any problem. And then you might make note again that CLL is the same disease as small lymphocytic lymphoma. Which name you give it just depends on where those cells are located. Then over on the right side of the table, we have CML. So CML may progress to AML, which is referred to as a blast crisis. So you have a CML patient with mature myeloid cells and various myeloid precursors, and they're just kind of cooking along. Then all of a sudden they start churning out immature myeloid cells, or those myeloblasts, and they've progressed to AML. That's a bad sign, and they need immediate treatment or they're going to die. Now here's a picture of a bone marrow biopsy from a patient with CML, and you see lots of myeloid precursors like promyelocytes and myelocytes and metamyelocytes. But what you don't expect to see is really immature blasts. Now CML occurs in slightly younger individuals, around 25 to 60 years of age, but the average age is around 55. So again, ML is for midlife. And then with CML, the Philadelphia chromosome is always going to be present. We're going to talk about what that is in just a moment. And then you can have fatigue and abdominal pain and also splenomegaly. And we've mentioned the Philadelphia chromosome a couple of times, so let's talk about that for a moment. Philadelphia chromosome is a chromosomal translocation 922. And that translocation occurs at a very specific site, which creates a very specific mutation called BCR-ABL, or sometimes we call it BCR-ABL. BCR-ABL is an oncogene. Now we'll discuss oncogenes in the oncology videos, but basically oncogenes are mutated genes that cause cancer. So the BCR-ABL oncogene encodes a type of tyrosine kinase that is constitutively activated. That means it can't be switched on or off. It's just always switched on. It's constitutively activated. And that leads to malignant transformation. So Philadelphia chromosome is always present in CML. We said it's sometimes present in ALL, and it's rarely present in AML. So to remember the Philadelphia chromosome goes with CML, I like this mnemonic of Philadelphia cream cheese. And the C and M in cream are for CML. And there's a drug that targets the Philadelphia chromosome called imatinib. It specifically inhibits that BCR-ABL tyrosine kinase. We're going to talk about that in oncology when we cover cancer drugs. Now, there are several other translocations that we've kind of mentioned in passing. Translocation 814 activates the c-MYC oncogene. We said that was associated with Burkitt lymphoma. You remember that handy visual mnemonic. Translocation 1517 is associated with the M3 type of AML, which is the one associated with lots of hour rods. And you can treat that with all-trans retinoic acid, or ATRA. And I also want you to write in translocation 821. So this is another translocation that can cause AML. And this is why patients with Down syndrome, or trisomy 21, have a higher incidence of AML, because you have an extra copy of chromosome 21, you have more chances of getting this translocation. It just makes sense. Let's briefly discuss myelodysplastic syndromes, which are a pre-malignant, pre-leukemic state. Myelodysplastic syndromes are disorders in which there's dysplasia of the myeloid hematopoietic cells. And again, it's a pre-leukemic state. It's not leukemia yet, but there's concern that it could progress to leukemia, especially AML. Now, just like if you saw cervical dysplasia on a pap smear, you'd be worried that it could progress into cervical cancer. Well, here you have dysplasia of the blood cells, and you're worried that it's going to progress to leukemia. So we keep a close eye on these in case they do become malignant. Now, you might want to be able to recognize this pseudo-Pelger-Hewitt anomaly on the peripheral smear, where the neutrophils have nuclei with two lobes that are connected by a thin strand, so that the nucleus looks like the old-fashioned pince-nez glasses that just pinch the nose like Teddy Roosevelt wore. Most patients with myelodysplastic syndromes are asymptomatic. And the diagnosis is only made after you find an abnormal CBC, and you end up getting a bone marrow biopsy which shows dysplasia and disordered hematopoiesis. Most of the time, we simply monitor these patients for progression, or we could treat with transfusions and growth factors as needed. Now we're ready for the end of session quiz, which is just one longish question. So pause the video, write in your answers, and then we'll go through them together. This question says, what form of leukemia matches each of the following statements? So the most common leukemia in children is ALL. Most common leukemia in adults in the U.S. is CLL. Characteristic hour rods is AML, specifically M3 AML. Myelodysplastic syndromes have a tendency to progress to AML. More than 20% of blasts in the bone marrow is an acute leukemia. Leukemia with more mature cells and less than 5% blast would be a chronic leukemia. TDT positive acute leukemia is ALL. Commonly presents with bone pain, ALL. Numerous basophils, splenomegaly, and negative for leukocyte alkaline phosphatase, that's CML. Always positive for the Philadelphia chromosome, that's CML, remember our Philly cream cheese. Acute leukemia positive for peroxidase is AML. Solid sheets of lymphoblasts in the marrow is ALL. And the last bullet, always associated with the BCR-ABL gene. Remember, BCR-ABL is the Philadelphia chromosome, so that's CML again. And now for the rapid-fire facts. Smudge cells are seen in CLL, and reddish-pink rods in the cytoplasm of leukemic blasts are the hour rods, which we said were a feature of AML. I'll see you next time.